All right, let's do this. So
Right.
welcome everybody. I want to start with a couple housekeeping things. Charlie is going to be speaking for about 40 minutes and then he is going to take questions. So if you have questions, send them to the chat and I will be reading those to him for him to answer. I am Kate Coley. I am the Associate Director of Alumni Programs at Rice, and I am so excited to welcome Dr. Charlie Dai. I was lucky enough to know Charlie in undergrad, and he was that guy on campus that everyone knew. He was a natural born leader. I am not at all surprised that he is one of these healthcare heroes on the front line up in Boston. And I am so appreciative that he took time out to talk to us. And I wanted to start with doing a quick cheers to him to thank you for joining and for all the work that he is doing to help keep
Cheers.
us safe. So cheers to you, Charlie.
All right.
And take it away.
Thanks, Kate. It's really a pleasure to be here, and I'm very excited to be doing this. I see on here, first of all, a lot more people than I expected, and then also, quite a few familiar faces. So I'm just very excited to reconnect with everyone. As you all know, I'm Charlie Dai. I'm a Rice 2012 alum, and currently a second-year medicine resident at the Massachusetts General Hospital. And a Weissman. And so to give you a little bit of background, I guess, a couple of weeks ago, this was kind of early on in the pandemic, Kate had approached me asking if I'd be willing to do this session. And around that time, there were really only a couple thousand cases in the US so far, and things were kind of just accelerating. But I had already started posting a little bit on social media, mostly regarding kind of the topic of social distancing. I recall that, around this time that, most states hadn't actually shut things down yet. But what was really kind of alarming to me, as well as many of my co-residents in the hospital, it was just kind of how little information was out there and how few people, recognized what was at stake with any delay in action. So things have kind of evolved a little bit since then. I'm still using Facebook mostly as a forum to try to offer some insight into how my hospital, as well as Boston as a city, has responded to this pandemic. Some of you may be interested in kind of these topics that I'll touch upon. And so I've made my posts public. Feel free to look them up or add me as a friend and fellow Rice Al. Kind of moving forward, I think a lot of the issues that I'll talk about I really chose because I recognize that some of them are privy to really only those of us who've spent significant time in hospitals during this period. And unfortunately, because our climate has been so polarizing that even a pandemic seems to have become political these days, I thought that offering just a personal perspective and in kind of like a casual setting like this could shed some light on kind of what things are like on the inside and help show the impact that this virus has already had on hard-hit areas of the country. As a disclaimer, I'll just say that, this is my experience alone and not necessarily a reflection on the opinion of other healthcare workers or my hospital. And then I also want to recognize the many other Rice alumni who are working hard on the front lines, including here at the MGH. Just to name a few names off the top of my head, this includes co-residents Nathan Al-Halal, who's in my class and in internal medicine and he was a Will Rice 2013 graduate. Also Cyrus Jizadin, who is Baker 15, and then some fellows as well, like Sarah Cromer, who was Sid Rich 2011, who I actually met or bumped into for the first time. I believe like one of my first weeks of intern year, she like popped into the ICU and we like recognized each other and we're like, whoa. So a small world. And then also Dania Day, who was Weiss 2007, actually. I didn't know this. I had met her at a meeting in DC, and turns out she's a interventional radiology fellow at our hospital. So I'm sure I'm forgetting a lot of people. So if I forgot your name, I'm so sorry that I left your name out. All right. So kind of just to move forward, I think that the goal of this session for me at least is threefold. Really kind of to distill out some of my experiences over the last couple of weeks for you. One, to highlight the amazing work that our hospitals have done here in Boston and across the nation in response to this pandemic. Two, to show that, what's at stake, really as we move forward in the weeks ahead, in the months ahead. especially as less affected parts of the country currently begin to see more cases. And then the last is to build community. I think this is really important, and recognizing kind of the diversity of work and the network that Rice alums span, even outside of medicine, and empower all of us to think about ways to try to join together and mitigate this pandemic together. So I guess I'll start by asking, what is it like to try to fly a plane while building it at the same time? I think that was the analogy that was used by our hospital leadership early on, and really reflects the pace of, how quickly things are changing and how dynamic things have been. To give you a sense of our accelerated timeline, so you all know that really the first cases of COVID-19 were reported out of Wuhan, China in late December. I think that in January and all the way into kind of the end of February, a lot of hospitals in the US, unfortunately, lost out on a lot of time in the preparation phase. There's a lot of reasons for this. I won't go into it, but we were relying a lot on the CDC and the federal government for action, and we were trying to strategically isolate people from high-risk areas. The huge flaw in this strategy is that we didn't appreciate the degree of asymptomatic spread that could occur. So early on, our hospital had banned non-essential business travel to high-risk areas. We also started furloughing employees who had come back from those areas. And then as providers, we had started asking our patients, if they had ever visited these areas or had any symptoms of respiratory disease. But really, we weren't anywhere near the adequate testing capacity that we needed. So even if you had overt symptoms, you needed to have a CDC-defined risk factor, which was an exposure to a positive individual or travel to a high-risk area in order to get tested easily by the state. And so this was very frustrating, both for my patients as well as for me and other providers. January 21st was an important day for the US. It was when the first case of COVID-19 was reported out of the state of Washington. And for us, COVID-19 was still very much a black box at that time in terms of what to do about it, how to manage it. We really didn't know much about it. And really, China and Italy were starting to publish small kind of studies on the disease. It's interesting to try to care for a disease that you've never learned about in medical school. And so, we were hearing that intensivists around the world were trading ideas on how to, safely and effectively manage these and stabilize these patients. And since then, we've actually seen an explosion of literature, that's kind of come out every other day. And so it's been really hard to keep track of. It's actually been somewhat like trying to drink from a fire hose. But you remain thirsty, and we're always learning more things about this disease. So in Massachusetts, we had our first case on February 1st. I don't think we were, as a community, mentally prepared for the widespread impact of COVID-19 and the impact that it would have on our health systems, at least not until reports came out from Italy towards the end of that month. I will say it was a chilling experience when I attended our medicine grand rounds on March 12th. And one of our infectious disease experts had actually informed the crowd that he had gotten an email from a colleague in Italy who had sounded the alarm and told him that their hospitals were completely overwhelmed. They were out of ventilators, they were out of beds, they didn't have enough critical care specialists to manage the surge, and so they were bringing out ophthalmologists and pathologists and retraining them to manage ventilators. And then the kind of really haunting thing that I remember is that he said that in the absence of any change, that we were about 2 weeks away from a similar situation. So that was revelatory, I think, in a couple of ways. The first is that, I think Italy has an excellent healthcare system, probably among the best in Europe. And so, the fact that they became crippled by this disease didn't bode very well for us. I also think that, in the US, we're susceptible to a little bit of hubris, and that we think that, because we spend the most money on healthcare of any developed country, that somehow our medical care is superior and that we're immune to the challenges of other countries, which is simply not true, and that was evidenced by Italy. The second reason I think this warning signal is important is that it made us realize that we weren't ready. So it became evident that the issue was not the complexity of the disease, but how many people would get the disease. So no one was really prepared for a pandemic. I mean, let's be honest. Nobody that's currently practicing medicine has experienced this kind of surge, at least in 100 years since the 1918 Spanish flu. So I had an attending tell me in the early weeks as we were rounding in the ICU that he said he thought he lived through a pandemic with H1N1 in 2009, but this was nothing like that, and this was far, far worse. So that I thought was interesting. And people will, they'll compare COVID-19 to influenza, and they still do. I admit that I was one of those individuals who, when cases first appeared in Wuhan, kind of dismissed the impact, maybe you would say, of COVID-19 and felt that it was maybe less severe than it was billed. However, the problem with COVID-19 is not necessarily the mortality of the disease, but actually, it's actually less lethal, I would say, than its counterparts like SARS and MERS. But really, it's the important factor is how infectious it was. So we just don't see influenza overwhelming hospitals in the way that COVID has, because some part of the population is immune. And it doesn't take much to know the difference when you start seeing entire ICUs fill up with COVID to understand that we're dealing with a very, very different beast. You've probably heard this, but based on kind of the notion of infectivity and immunity, in the mathematical models early on, if the experts suggested that if you just let this virus run through a community, the estimates were that in the absence of a vaccine, about 50% of people would have to become immune through infection in order to slow the spread. So if you do the simple math, in the United States, even a mortality of 1% would mean millions of deaths in the US. And this obviously doesn't factor in the emotional and the psychological and financial toll on the volume of hospitalizations for severe and critical illness. And then unnecessary deaths as well if you run out of ventilators. The reports from China at the time showed that about 20 to 30% of symptomatic cases were actually requiring hospitalization, which is a huge, huge burden for any healthcare system. So interestingly, I actually learned not that long ago that the annual deaths from flu, which we always talk about, are actually estimates rather than a true survey of broadly tested communities. So that's the difference between COVID-19 and influenza. Important to recognize, because there's actually some margin of error with those figures if you're hoping to compare death counts from COVID-19 to influenza. And it makes a lot of sense actually for what I see in the hospital, because observing and witnessing patients die from flu is actually a very rare occurrence. Unfortunately, though, in the last couple of weeks, I've seen more patients die from COVID-19 than I had in the previous year from all other respiratory viruses combined. So I think that that's something that people really need to understand. It's a very different world when you see things in the hospital. So our timeline changed in an important way in early March when the Biogen incident occurred in Boston, Massachusetts. So this was an outbreak at the conference that was hosted by this pharmaceutical company where many employees had been to Europe and other areas and brought the virus likely back with them. These patients arrived to our hospital for care, and we realized that we just couldn't have them walk in through the front door of the emergency room, at least not without putting healthcare workers and other patients at risk. So our hospital had to quickly design and scale up a bay to start triaging higher volumes of patients, as well as ramping up testing clinics and isolation spaces. I happened to be working in the emergency room actually around this time. It's interesting because I look back, and at that time, that from an epidemiological standpoint, if someone came in with a fever and a cough, they were much more likely to still have the flu or a respiratory virus than other respiratory virus than COVID-19. It wasn't really easy to parse out which patients needed evaluation given unclear epidemiology. We would just say, well, you weren't in China, you weren't in Italy, you weren't exposed to anyone who had COVID, as far as we know. So you should just go home and self-isolate. But this was prior to our understanding of the prevalence of asymptomatic transmission. And given that the state health department was restricting testing to only people who met those CDC-defined criteria, I think we were really flying blind. So we had to get approval for testing from our infectious disease team before we were able to send off a tool or a test. And really, I think that there were a lot more cases out there even then than what we were reporting, as was kind of suggested by a recent study out of Northeastern that said that, but at that point, our cases were already, in the thousands probably, even though we only had a few individuals who were testing positive. The other challenge was we were telling patients to go home and self-isolate without really a clear, protocol on how to do that. And so, all of this was kind of just created the perfect storm for confusion from patients as well as from providers. Because of testing limitations, our hospital actually developed its own PCR test, independent of the CDC. The state test was taking about 5 days to return, which made it incredibly difficult to act on and pursue any form of contact tracing. Our in-house test, on the other hand, was taking about 12 hours to return, but we couldn't scale it up for some time due to limitations in equipment and staffing and such. But we were lucky as a community in that Boston has a lot of biotech resources, and so we were heavily dependent on some of these companies to help us with this. There were also challenges in determining the positivity of a test, since really only 7 out of every 10 people were correctly diagnosed with COVID-19 on the first run. We would miss out on a lot of cases on the first pass and needed to repeat testing on the majority of people to ensure that a negative test is truly negative. And really in the last couple of weeks, though, I'd say we've hit a stride. Now we've been able to test thousands of people in Massachusetts, kind of at a level that we really should have been able to do, even very early on. So that was a lesson learned. Hospitals in the US were also ill-equipped, I would say, with respect to PPE and training of staff for isolation protocol. So you basically had to get the entire hospital trained on how to don and doff properly, which is actually a kind of a complicated process if you want to do it the right way. It's a different order putting it on than taking it off. And there's a lot of errors potentially that you could make along the way. It also showed us kind of how, as a hospital, we weren't really doing PPE the right way before this. And then there were also these changes constantly to the policy. First, it was only providers wore masks when entering rooms, and only N95s if you were going into a high-risk room of someone you knew had COVID and who had an aerosolizing procedure. Then it was everyone wore a mask at all times, and then you were required to wear an N95 for all positive COVID rooms. And then initially we were throwing out single-use masks, and then we ran short on them, and so we were being asked to re-wear them, but had to learn a technique on how to not touch the front of it when putting it on and taking it off, unless we wanted to contaminate our faces. There were concerns from staff about aerosolizing viral particles using respiratory equipment like BiPAP and high-flow nasal cannula. So we were trying to avoid these therapies. The problem with this was that we couldn't offer them to decompensating patients. So often patients were getting intubated and put on a ventilator early who otherwise wouldn't have needed to. We're also limiting CT scans and echoes and other tools for evaluation that we were used to having done and having available for our interpretation, because these kinds of imaging studies required a lot of effort and risked a lot of contamination. And then here's kind of the craziest story. So as PPE use went up, we started seeing a lot of shortages. And so you may have heard this in the news, but Governor Baker of Massachusetts was able to procure over 1 million N95s from China through a third party. However, the state actually was honest about this and said that there are challenges transporting the masks back to Massachusetts. So Jonathan Kraft, who's the son of Robert Kraft and the president of the New England Patriots, he sits on the board of our hospital. And he came to the rescue, funding the effort in part, and then also offering up the Patriots team plane, which was a Boeing 767, to transport these 1 million masks from overseas. And to my limited understanding, there was a lot of red tape involved in getting past like the FAA and the federal government. And it just really showed how poorly positioned individual states were compared to the federal government in kind of coordinating these large scale efforts. And then, I felt that it also represented a real, a resource maldistribution problem, because, how is a smaller hospital supposed to do something like this? Like, there are places in the United States, like rural areas, where we don't have these type of resources, and they can't, pursue these kind of Herculean efforts to protect their healthcare workers. So this, I thought was just kind of an insane story to remember. So in terms of my personal experience, the first patient that I took care of with COVID was actually a healthy gentleman. He was a hospital worker. And I think seeing him get rapidly intubated was a jarring experience for me, in that it kind of brought to appreciation my own mortality in a way that I hadn't thought about before. The same week, I also took care of a college student who was found down, intubated, and then found to have COVID-19 afterwards. and he ended up having a large pulmonary embolus, a clot in his lung. So, you know, although I treat a lot of different diseases in the hospital, I think very few of them do I actually worry that at the same time I'll be the next person to contract this disease. And then as I was seeing more and more patients, it became evident to me that the majority of patients coming to the hospital were people of color. So we escalated this up to the leadership of the hospital as well as to the state, who, you know, went to do some contact tracing and identified a major outbreak in the neighborhood of Chelsea, Mass, which is a large minority population. And it was difficult because a lot of these patients are Spanish speaking, and the isolation protocols made it difficult for us to use hospital interpreters to assist us with communication. And so it was awesome to see, but a bunch of, you know, Spanish speaking physicians formed a team impromptu and went around the hospital basically just talking to patients and their families and explaining what was going on. I thought was a very compassionate thing to do. Other shocking experiences for me were just seeing the number of, you know, families admitted. So there was, you know, husbands and wives, sons and daughters, grandparents. Sometimes one family member would get discharged, another one would get worse, and then have to get intubated and placed on a ventilator. Because we were restricting visitors from coming in, you know, if you had COVID-19 and your family member, and you were at home quarantining and your family member was dying, there's no way you were going to be able to come and see them. And so we didn't have a way to deal with this really in the beginning. So we were improvising by taking our own personal cell phones out and putting them in Ziploc bags and bringing them into the isolation rooms to live stream with patients and their family members. And then we were also trying to, you know, call each family member every day, which became a challenge, you know, from a workflow standpoint. Families were really confused and had a lot of questions about what was happening with their loved ones, not being able to actually see them. And so it was clear immediately from this that the community spread within families was going to be really difficult to control, especially where people live in very close shared space. In March, Governor Baker, he ordered a shutdown of private and public schools, as well as a ban on large gatherings like bars and restaurants and other public spaces. And then we also had a curfew that was enacted. As a hospital, we shut down basically all non-essential hospital services like elective surgeries and such. We also canceled clinic appointments and made them all virtual through live streaming. And you know, so most of us had never done live streaming telemedicine appointments before, so this was a new skill set to be learned by, you know, a whole generation of primary care physicians. But one that's probably been coming for a long time, because I think, you know, we're all kind of realizing that, you know, a lot of the time you don't actually have to go into clinic for a physician to know what to do for your care. And so it was actually convenient for a lot of the patients who were able to get their telemedicine visits. Our hospital during this time also rapidly expanded its capacity within several weeks, which was an amazing thing to witness. Actually, the first couple weeks leading up to the surge were a little bit unsettling, actually, in that there were less patients in the hospital than we were used to because of cancellations from non-essential services, and also patients opting to stay home, you know, and delaying their care. So it was actually quiet. We had a lot of open beds. We were down like 30% in terms of our capacity, and the feeling was honestly a little bit like watching the water recede before a tsunami. And we knew that things were going to get worse, and they got worse pretty quickly. And you know, during our peak, we had over 50 people admitted to our hospital in a single day. So to give you a sense of the numbers in context, our hospital maintains about 2 medical ICUs, each with about 16 beds. This is far more than most hospitals since we're an academic medical center. Our community hospital affiliate, just for comparison, has a single ICU with 10 beds. And so, you know, over the next couple of weeks, we were filling both of these medical ICUs with COVID-19 patients. So we started repurposing other ICUs instead of, including our cardiac ICU, our neurological ICU, our pediatric ICU, our burn unit, our post-surgical recovery floors into COVID care units as well. We stopped admissions for chemotherapy for our oncology patients and brought in ventilators to change those floors into ICUs. And through this, we were really able to expand our capacity to up to about 150 ICU beds. You know, this is kind of a really incredible thing, considering that there are parts in the country where there's one ICU bed for the entire community. And so to have access to 150 was a really, you know, exceptional thing, I'd say. But creating the beds was only half the battle. You know, we needed to find people to staff these beds. people with ICU experience. So as part of the internal medicine residency, I saw that we had a large footprint in this, and that senior and junior residents, including myself, had spent much of our years kind of training in ICU settings. So we were kind of a perfect plug and play strategy. And so they took us and redeployed us on all of these new floors, filling our previous roles with other kind of non-critical care attending doctors, subspecialty fellows, non-medicine physicians and surgeons who could do those roles. And then we kept our original medical ICUs for the sickest of the sick, and the new ICUs for kind of less but still sick patients, because the nursing staff on those new floors were less familiar with caring for COVID-19 patients. So they were learning on the fly how to do this. There were also hundreds of patients who didn't need ICU care, but did need oxygen therapy and other kind of medical interventions. So they were admitted to the regular floor. In order to bring those people in for staffing, we enlisted non-internal medicine residents, such as radiology and surgical residents, to help. And then we also brought in fellows, including, one of our Rice alums, Sarah Cromer. She's working on a surge team. And I spoke to her just recently. We also had supervision by medicine physicians and critical care doctors. So there's kind of really a rapid distribution of expertise and knowledge. And we were like basically playing musical chairs, switching patients around from floor to floor until we could get all the COVID patients on one floor and the non-COVID patients on others, in order to, isolate them so that the non-COVID patients wouldn't accidentally be exposed. So from the hospital leadership perspective, it was like an incredible thing to see. The whole experience was kind of like, it honestly felt a little bit like being at war. Our hospital made an announcement to healthcare workers that they were being asked to join this effort, regardless of your age, young or old, and people were coming out of retirement to help out. And, I think a lot of people felt very galvanized by this, and very few people hesitated to answer the calling. But our hospital did say that, in their statement, that this response is mandatory, and if you didn't come to work, it could lead to you being fired or other consequences. And so I did know of people, like one respiratory therapist, who quit because he just had to take care of his mother and couldn't risk contracting COVID-19. We were also rationing medical supplies, PPE notwithstanding. We had run low on certain medications, and we're using other medications in replacement. We also had colleagues who were coming down with COVID-19. And I believe the numbers most recently are that about 400 employees have tested positive at our hospital for the virus, despite kind of precaution. So in order to manage the flux in staffing due to sick leave and all the stuff, people getting sick and being furloughed, we had to redesign our work schedule. So there was this huge backup pool of providers who could sub in at any moment in case we had a large outbreak. In the beginning, when there was a lot of confusion and we hadn't refined our infection control policies, we had a situation where a whole medical team ran into the room to respond for an emergency call for respiratory distress, only to find out later that the patient was under investigation for COVID. And so everyone got furloughed for like a week. And so that was, really challenging. I personally was furloughed as well after developing a sore throat, and I was tested and negative twice. But the test came back 5 days later. And so I was just sitting around feeling really anxious and wanting to get back to work. At one point, our hospital began to review its crisis centers of care, which are basically guidelines for what we would do if we ran out of beds and ventilators, how we would ration these commodities moving forward. So the way it was supposed to work was that every patient would be given a score based on their overall medical condition and prior medical issues. And so if there was someone who came into the hospital who desperately needed a ventilator, and the ethics team would be asked to weigh in on whether or not to palliatively extubate other patients who had kind of poor scores in order to open up machines. And this was like a really utilitarian way of ensuring, maximal survival across populations. There are a lot of concerns from our community about how to do this fairly and equitably, especially because a lot of our patients were from vulnerable populations. And then I also remember in the Q&A, if someone asked if healthcare providers would be given priority. And I think whether or not this is the right thing to do is definitely up for debate. But it certainly changed the calculus of things when we heard about this. And it became that much more real when we heard that we had lost a colleague and leader in Dr. John Stokel, who is a professor emeritus and kind of a legend at MGH. He passed away from this virus a little bit ago. In the beginning, things were tough. I think emotionally, patients weren't really doing very well, and they were being vented for several weeks at a time. And we were pulling out breathing tubes and finding that people weren't ready to breathe on their own, so we had to reinsert them. And then we had a few really sick people who died early on, despite a prolonged fight to keep them alive. We also saw some unintended consequences from kind of misinformation about COVID-19. We had a few cases in Boston of hydroxychloroquine overdose seen in our ICUs, which was a terrible thing to see, but kind of an interesting thing to manage. None of us had ever seen this before the era of COVID-19. We were ramping up clinical trials, including those for hydroxychloroquine and remdesivir, but at least anecdotally in the ICU, there weren't many of us who really believed that these drugs would be game changers. We were still kind of just providing respiratory care as kind of the mainstay of treatment. But despite all of this, we did see glimmers of hope, including one patient who was placed on ECMO, which is lung bypass for basically the most direly ill of patients. And he was actually in the news recently after having been intubated for 32 days. He ultimately recovered and was discharged to rehab. And so we were all celebrating this moment when it happened. The city's response to COVID-19, I think, was the most incredible thing to witness. To prepare for the surge, Boston hospitals banded together, with surprising solidarity, I would say, because our healthcare system has kind of long been characteristically fragmented. Individual hospitals have been siloed by things like competing financial interests, U.S. News and World Report's rankings, and we don't even have a common EMR across the hospital. So every time a patient is admitted to MGH who isn't in the healthcare system, we have to have people fax over the records or like look for them. It's really a pain. A few weeks ago, one of the hospitals finally shared its medical records with us so we could easily facilitate transfers. So we were all left kind of wondering why this wasn't possible before. So that's kind of one example of positive change, I guess. But hospitals were really supporting each other to share the burden and offset the burden that this virus was having on specific communities. Just to name some examples, Brigham and Women's Hospital started taking transfers from MGH. And then Boston Children's accepted all pediatric patients across the city and allowed us to turn our pediatric ICU into an adult COVID care unit. So pediatricians were taking care of like 90-year-old patients, which is incredible and also kind of scary. And then hospitals were also donating supplies to each other, like ventilators and dialysis machines, and we were sending over our own critical care specialists to community affiliates, including one hospital that had been completely overwhelmed by the outbreak in Chelsea. And so this collaborative spirit and the collectivism that we were seeing was really refreshing. We also saw a lot in terms of the community efforts by individual hospitals and the states. We had volunteers assemble care kits comprised of masks, hand soap, and other supplies for low-income patients, as well as undomiciled and undocumented residents. Local organizations were donating food to families in need. They repurposed inns for isolation centers for patients who otherwise couldn't have self-isolated due to shared housing situations. Our medical students had been calling patients and their families to educate them about COVID-19. And then our EMTs had been doing things like in-field testing and visiting patients after discharge to deliver continuity care in their own homes, which had really not been heard of before this. You also may have heard in the news that the Boston Convention Center was repurposed into a subacute medical facility called Boston Hope. This allowed us to rapidly decant our patient volume, freeing up beds for the most sick, and then having the rest of these patients be cared for at the convention center. It also allowed us to reserve spaces for patients experiencing homelessness who couldn't return to a shelter. And our healthcare for the homeless team was working very hard through this whole process to implement universal screening and case tracking to limit outbreaks in shelters. What came out of that actually was an interesting finding, as well as a study out of Chelsea that showed that a significant proportion of people were walking around asymptomatic. One shelter, homeless shelter in Boston, tested 400 individuals, of whom 36% actually tested positive, but less than 10% of those 36% had any symptoms. So that was kind of a revelation for us. And then also in Chelsea, where the outbreak had happened, we did random testing for the presence of antibodies and found that over 30% of randomly tested individuals had prior exposure. So if you applied those numbers to the community at large, you were seeing that far more people were carrying the virus than what we were seeing. And so our hospital was among the hardest hit, I'd say, of hospitals in Massachusetts. At one point, we had over 350 patients from COVID alone in our hospital, and over 150 in the ICUs. But we've reached a plateau, and we've seen our numbers decline in the last couple of weeks, mainly due to social distancing and other efforts. And we never really had to invoke our crisis standards of care, so we were able to have some breathing room and really take care of the patients, that we had in a way that we always have. And so we've been very fortunate, I would say, to not have been hit as hard as New York. And so my thoughts go out definitely to our colleagues out there who continue to fight a very desperate fight against this virus. For us, it seems like things are on, good things are on the horizon as our numbers go down each day. And we've actually seen that our mortality in the ICU is about 15%, which is lower than figures out of China, Italy, and New York. I think it's really a proof of concept that what we need at the local and the national level to mitigate this pandemic are really things like adequate time to prepare, a proper supply of ventilators, scalable contact tracing and isolation, and resource redistribution, really making sure we protect our most vulnerable. I think that can't be emphasized enough. None of these are really easy, but when we band together, it can be done. And so as healthcare workers, we're very thankful in the state of Massachusetts for the great leadership from our hospital, city, and our state that allowed us to mobilize quickly. So where do we stand now? I think it's worth noting that our hospital capacity is under more stress actually than it was during the peak of COVID-19, and you may be wondering why. It's because we reopened floors for non-COVID patients, and we're seeing patients present with delays in care. So the last week, we saw some pretty sick patients, and I wonder if some of that was due to patients stalling to get their care out of fear of catching COVID-19 in the hospital. It's remarkable, I think, because our cardiac ICU, for example, is normally filled with people who have had heart attacks, and now is entirely being used to treat patients with COVID. So I'm not sure where all the heart attacks have gone, but people really need to know that if they're not feeling well, that they need to come to the hospital to get their care before things become unsalvageable. Our cardiologists were actually saying that they expect more late complications from heart attacks, which were previously rare, given that how good we've gotten at managing heart attacks quickly. And then, we've also been strategizing on how to de-escalate, but also rapidly redeploy if a second wave hits. We've seen from Asia that relaxation of social distancing has really led to more outbreak. And so we know that this is not the end, but rather the end of the beginning. So, you guys might be curious about what the hospital is like right now. I'd say that, the first thing that I noticed is that it's really quiet, and that we've limited the presence of visitors and non-essential personnel. So we have security guards who stand at the door and screen people for COVID-19 for symptoms of COVID-19 before allowing them to come in to the hospital. And then we wear a mask at all times. We're given a new one with every shift. We've also limited capacity in our public spaces and break rooms so people are socially distanced. From an educational standpoint, for our residency program, we converted all of our lectures into virtual Zoom meetings, so things definitely feel a little bit more isolated. When I get into the hospital, I put all my personal belongings in the call room where they hopefully won't be contaminated, and then I put on my scrubs, and there's a lot, and I mean like a lot of hand hygiene. Anytime you touch anything, anytime you touch your face, or put on your mask or take off your mask. And even codes are kind of quiet because everyone has to slow down to put on their gear before running into the room to start chest compressions and resuscitative measures. And we bought a Lucas, which is a machine that you can place on a patient to do chest compressions for you, since we were finding that a lot of patients' masks and goggles were falling off a lot of people's masks and goggles were falling off during CPR. So at the end of the day, I change out of my old pair of scrubs into a new pair, and I clean everything off, like my phone, my pager, and my badge before I leave the hospital, and then again when I get home, and I shower immediately. And I think like the hardest part of this is walking back from work, and then you see people like on the lawn throwing a frisbee or picnicking like there's nothing wrong. And that's, I think, the hardest part when I see states reopening up too quickly, is realizing that if people saw what was going on inside hospitals at the epicenter of the pandemic, I think a lot of people would think twice about our current state of affairs. And no part of the country will be inherently spared from what has happened in places like New York and Boston and New Orleans and other cities. So that's why I'm happy, very happy that they asked me to do this Zoom session. And I hope that I've been able to communicate, at least to some degree, some of the salient challenges and issues that our hospitals face on the daily. And watching the news can be overwhelming. It can be kind of like watching a slow motion train wreck. But I've learned to limit my news intake and distract myself on my days off. It's the worst when you see experts like Dr. Oz and Dr. Phil go on to TV and offer their quote unquote expert opinions, which are clearly not representative of the medical community at large, and terribly misleading and filled with falsehoods. But I think as a community, we have as a healthcare community, I think we have felt very loved by the outpouring support from family and friends, as well as strangers. Sharon, my fiance, has been really honestly the anchor for me during these emotionally tough times. And we're thankful for the free meals, the shoes, the other swag that we've gotten. But I think many of us healthcare workers also feel that this energy and this desire to help are misdirected potentially. And really what we should be doing is supporting our vulnerable populations, our small businesses, our elderly populations, and many, many others who are struggling right now. So I encourage you to consider donating to an organization you believe in to support the cause. So just to close, I think, we stand at a defining moment in history, and how we decide to face this as a society will really have longstanding implications and repercussions, not only from how we tackle this disease, but also from how we choose to support and lift each other up during this time of need. The pace of clinical care is evolving at a tremendous pace for the treatment of COVID-19. Those of us who are in training realize that this will be a special moment in our careers, much in the same way that HIV/AIDS were for a generation of physicians decades ago. And we do have faith that we will overcome this disease. Like many other human diseases, we just need time. Social distancing will continue to buy us this time. And so we're reassured when we see people committing to this strategy. And so this is likely the beginning of the end of the beginning for Massachusetts. The numbers seem to be going down in Boston, New York, and New Orleans, but actually they're going up in other areas of the country when you take out those cities. So our hospitals remain stressed, and the MGH actually reported about 5 million in net losses per day. And this is even in the absence of any hazard pay, and employees are still showing up to work each day out of the sense of duty and responsibility. So I really think that opening the country without proper contingencies would be a terrible betrayal to our healthcare systems, and we should not accept that easily. The seropositive prevalence and unclear immunity of populations in the hardest hit areas suggest, that more outbreaks could occur. So remember that the 1918 influenza pandemic had actually 3 waves. The first one affected the vulnerable, including those who were living in poverty in close quarters, and were thus most exposed to the disease. But the second and the third waves affected everyone, and they were ultimately more deadly than the first wave. And so we should not allow ourselves to fall towards this creep of complacency. But despite all of these worries, I do want to end on an optimistic note and point out that we will emerge from this crisis as a stronger society. So we are learning how to be socially distanced and yet remain connected, as the Zoom for Rice Owls has shown. And I also think that this pandemic will challenge us in a way more than we've been challenged before, to think about how to care for our most vulnerable, and how allowing social determinants of health to remain unaddressed affects all of us. It helps us, I hope it also helps us reconsider the paradoxical notion of having our healthcare coverage linked to our employment, which is something like a pandemic could easily cripple, and it's already started to do so. When we talk about returning to normalcy, I think we should think long and hard about what that means and seize the opportunity to innovate and improve our world in a way that we never thought was possible. So although COVID-19 has fundamentally challenged us in the way we understand our world, and for me, the way we practice medicine, what remains a constant anchor, I think, in these turbulent times is really the natural reflex to embrace others with compassion and with empathy, and to help those who are suffering. And I do think that this is an intrinsic part of what it means to be human. And so despite the fear and the chaos, it's clear to me now than ever that the world is full of love. And so with that, I thank you for your time and your attention. And I'd like to open this Zoom chat up for any questions. Thank you.
All right, Charlie. Oh, that was fantastic. So I'm sure you're seeing in the comments, people are loving you. And one of people's biggest concerns are your health and fellow healthcare workers, mental health especially. And if things are happening around that, is your hospital doing anything? Has there been a move in that to make sure that y'all don't get burnt out during this time?
Yeah, I think our hospital has, and I think, you know, probably more so now than ever, because we are realizing that there is some degree of personal sacrifice that comes with going to work every day. And so our hospital has done a lot of different things, like one, open up, you know, places for tired hospital workers to stay and sleep if they need to. And hotels in the area have actually offered their facilities to enable this. We also have support groups and like employee wellness and other organizations that have really, you know, sought to stay connected with employees and people on the front lines to make sure that we ourselves are healthy. And, you know, it's funny because my schedule right now is actually easier than it was before the COVID-19 pandemic, which kind of shows you actually how like crazy residency is. And that they realized, you know, working 24 hours straight when you're on call is really not a great way to stay healthy. And so our residency program and residency programs across the nation have really cut down on the hours for residents. And that's really also been only possible through a lot of other physicians, including physicians out of training coming back in to support each other. So I think overall, I think our spirit is positive, and we are overall optimistic that things will get better. Though certainly wellness and kind of things like depression, anxiety, and other mood disorders are and psychological health remain at the forefront of, you know, of kind of managing ourselves as well as the COVID-19 pandemic.
Cool. So Emily asked, because the greater spread also tends to be asymptomatic and milder cases that recover on their own, what is the real rate of serious hospitalizations that risk death or lung damage?
Yeah. So I think it's hard to say. And part of me wants to err a little bit away from serving as a content expert, because I think that things are changing so quickly that what I say today could be different tomorrow. But I do think that there's a lot of asymptomatic transmission, more than we appreciate. And so when we come out of this, the lethality of this disease will likely be far lower than we initially expected. However, it's because of the lack of immunity that our populations have that makes this virus so, you know, infectious and has such an ability to overwhelm hospitals. And so I think from a personal standpoint, we just have to be really mindful, maintaining proper hand hygiene, social distancing, wearing a mask, not necessarily to protect yourself, but to protect others from your respiratory droplets, and doing all of these things consistently. You know, from that standpoint, I think we will be able to control this disease, and we will come out of this with hopefully the majority of people feeling like it wasn't such a big deal. The worst would be, you know, we come out of this and allow after allowing this virus to run through our communities, and everybody knows somebody who's been personally affected by COVID-19.
Here's a question that really hits close to home for all of us, and what we really want to hear from you is, if you as a healthcare provider could change one thing, what would you ask to be changed?
Oh, that's a typical question. not have COVID-19.
Well, yes.
Let's go back to November. Oh man, I think that's tough because, you know, a pandemic like this was bound to happen. Actually, there are, I believe, 7 coronaviruses known to man that cause disease, and 3 of which we have, have really emerged in the last 2 decades. There's SARS, MERS, and now COVID. And we've seen kind of an acceleration of disease, actually, of these new diseases coming forth. So I think, like, as a global community, we should have prepared for this a while ago. It's just unfortunately human nature that we wait until the last minute. And so, in terms of our response, I think, like, I would love to see more coordination from a federal level, because I think it can be done, because I think that other countries have been able to do this and have been able to limit spread. However, I totally get the notion of personal freedoms and the challenges that this has, on a country like ours, where individual freedom is so important. But I also think that it's kind of the government's responsibility, and I don't want to get political, but I think it is the government's ability and responsibility to support people during the pandemic. So, people are worried that they're unemployed and that they can't go to work, and that, they can't pay for their medical bills. But that's the reason why we have the government, and we have systems in place to support people when they can't support themselves, and that other people who can support themselves really should be looking out for each other, because when one person falls ill, everybody is affected. And that's something that is more evident with this pandemic than ever before. So I think I would love to see, more thought on how to, support people financially, and also, in their own health at a community level, before they show up to the hospital.
So what does it look like in the hospitals going forward? I know it changes every day, and there's really no solid answer to that, but is there, even in the next 2 to 3 months, how will things change in the long run, do you think, in this way?
Yeah, that's an interesting question. We do talk about that a lot, about, like, the ramifications of COVID-19. It really depends on when this pandemic will end. I am optimistic for the development of a vaccine, but probably not in the near future. And so we will have to adapt and just recognize that there will always be some amount of community spread at all times. But we can limit that by being really careful as a community, and everyone, being consistently committed to social distancing and such. I do think that, like, everyone has experienced personal loss in one way or another and been affected by this pandemic. My heart goes out to, all of the graduating seniors who can't walk the stage to graduation, who have to do it virtually, all of the Rice students who lost their beer bike. These are all things that, we care a lot about. And I get that there's, also, people who've experienced greater loss, but that doesn't mean you can't mourn, how COVID-19 has affected you personally. And so, moving forward, I think we will need to recognize that things are going to be different, but we are primed to be able to manage this virus in a way that society and civilization has never had. We have all of the tools to do this. We have video conferencing, we have apps, we have global connectivity. So I think we can do this. It's just we just have to be thoughtful and kind of innovative. So.
For one last question, and this is, I know you've answered it, I just think it definitely bears repeating, from Brooke. As states are reopening, what practical advice would you hope that the general public follows?
Yeah, so I think being cautious is the most important thing. And I say this because, and I wrote about this actually on Facebook not too long ago, but Sharon and I went biking to go grocery shopping recently, because it was really nice out in Boston, and we had really been at the limits of kind of cabin fever. And so when we went out, I was really anxious, and I couldn't at first pinpoint why. And then I realized it's because, like, when I'm in the hospital, I'm so used to being very, very careful. with everything. So before I touch my face, I wash my hands, even if it's just to itch my nose. I'm very, very careful. Donning and doffing PPE, realizing who I'm standing next to, all these things. But when I go out into the community to go shopping, for instance, at a grocery store, I lose some of that control because there's other people who are not being as careful. And because of that, I don't know what's contaminated and what's not. So I think that, mitigating this virus, what it requires is community responsibility to be careful. So the kind of reckless behavior of, not donning a mask, of, not washing your hands, it doesn't help anybody. And it's not a hard thing to be able to just do those simple tasks. And also kind of foregoing large gatherings for now. It's going to be tough, but it has to be done, I think, because we've already worked so hard to try to stop this virus, but we've kind of only done it like, half. I kind of say like half-assed. It's just like we aren't really closed down, but we're not really opening up either. And so people are experiencing the economic and personal challenges of having to stay home without us really getting control on this virus. So we got to do it one way or the other. That's what I would say, but it's no easy answer.
Yeah.
A lot of smart people are thinking about how to do this.
Well, it's tough. It's a new world. Well, Charlie, this has been amazing having you. Hearing your perspective has really been enlightening, and it was great to see you. And thank you again. This was really, really amazing.
Yeah, it's been really an honor to be able to reconnect with all of these Rice alums, and really fun. So I look back fondly on my time at Rice. One of my favorite things was just the community. And so thank you all for your time.
Yay. All right. Thank you. And thank you for everyone for coming. Stay safe, wear masks, and social distance.
Cheers.
Cheers. Bye, everybody.
Yeah. Bye.